and welcome to Coproduce Care. So today we have with us the lovely Jess Morley, and Jess will be talking to us about NHSx and AI and what does the whole digital debate mean in health and social care. So really excited to have Jess on. It's fantastic that we have someone to talk about NHSx. I'm really excited. Okay, so let's get going. Welcome, Jess.
Hi, thanks so much for having me.
Thank you for coming on. So when we had our interview chat, we talked about what you're doing and the organisations you're involved with, and there are a few. You're wearing different hats. So I'm not even going to try and go into them in too much detail. I will let you explain what you're doing.
Sure. So I do a number of different things, but with NHSx is probably where that's the hat I've worn the longest, as it was previously Department of Health and NHS England. And so I've sat in the Department of Health since 2017. I've worked for the NHS for a long time, but Department of Health since 2017. My role there at the moment is to be their AI subject matter expert. So essentially I kind of provide specialist advice with regards to the more technical aspects of what we might want to concern ourselves with the use of AI in health and care, and helps make sure that the policies that we develop, I guess, are appropriate for the actual technology itself.
Great. So one of the things I wanted to do is just break that down a little bit. Could you explain what NHSx is? Because I know there's an NHSx and there's the NHS Digital, and some people might not even know what either of those are, but I think it's quite useful to sort of explain and set out how they're different, and what NHSx, which is quite new, it only came into being I think in summer last year, so what it's hoping to do.
Yeah, absolutely. So NHSx is a joint unit between the Department of Health and Social Care and NHS England. It's not a new statutory body, so it is effectively just a joint team made up of staff from those two organisations. And it's the staff who work on anything to do with digital data or technology policy. And you're right, it came into being, we soft launched in June of last year and then sort of became a bit more official from October of last year. And its aim is to make sure that clinicians and patients and the wider workforce have the technology that they need, which primarily means making sure that things have, like, do we know where information is flowing? Do people have the information that they need about the patient that's in front of them at the right time? Are people enabled to live at home on their own and to care for themselves if that's what they want? So that's kind of what NHSx's job is. It's got 5 missions which all sort of flow from that core concept. NHS Digital is a body in and of itself, so it's not a joint team in the same way that NHSx is. And NHS Digital is primarily responsible for the NHS's core infrastructure. And the NHS has a thing that's called the spine, which is where all of the stuff like your medical records, etc., are stored or run through the spine to make sure that we can identify people through different points of the care pathway. That's just one of the things that NHS Digital might look after. And then NHSx does everything that sits on top of that core infrastructure.
And in terms of AI, why was your role created? What was sort of like the difficulties or the worries that were sort of considered that needed to be addressed?
Yeah, I think that's a really good question. So previously within the department, I was the technology advisor. So I covered a much broader range of technologies, and anything through from like the NHS app to the role of digital and social media on children and young people's mental health. And then we slowly transitioned into the role I have now with AI. And AI can be artificial intelligence, can be augmented intelligence, can be ambient intelligence. People use it in different senses to cover a broad range of different types of technologies that largely mean, when can we get a software or, like you say, some type of assisted technology to complete a task that would require intelligence if a human was to do it? And the reason why we sort of created my role, and there's a whole team. I sit within a wider team. There's a director of AI who is Dr. Indra Joshi. She's a clinician. And we have a few other clinical specialists in the team, was to really make sure that we are looking at the use of automated systems in the right way. There are a couple of issues, well, a whole load of issues, but you can broadly categorize them into the data. So there are issues to do with the data, like data access. Are we using it appropriately? Is it keeping it people safe? And then what happens when you deploy a system like that? So you are effectively removing, to a certain extent, the human from the loop. And that can have multiple implications, whether it be from a patient safety perspective or could it have unfair impacts, so that we're biasing care in favour of one type of person over another type of person. These are all issues that the government really needs to be aware of before it starts pushing these things as a strategy. And that's kind of my role, is to make sure that I can translate between the technical aspects of what it actually is and the sort of policy social science aspects that we need to be aware of, and make sure that we're not doing something that could be harmful.
I think that is such a vital role at the moment, especially where, I mean, I didn't realise there were so many different types of AI for a start, but also when we're going to conferences or we're talking about care, the issue of technology comes up all the time, and it's so fast and it's being promoted in such a positive manner that there's almost not enough time to critically reflect about what we're doing and the impact. We're just being told and encouraged to do it. So just having a body like yours that's looking at the effects is really important. So presumably you're going out and doing research or talking to people who are using these technologies. Is there any type of risk or issue that is coming up which you feel is quite a common issue in using technologies for people who are being supported or cared for?
Yeah, sure. I mean, there are lots, and I think I'm always quite conscious. One of the things that, for example, understanding patient data, always make this point, and it is a very important point, that there is no one type of group of patients or people who are in care. That everyone is very, very different. So it's important to not overly generalize. Different people will have different problems. I think the issue that we have with care in particular, and there's some really, really good research that's done by everyone in this space, is that there isn't so much data generated on the care process as there is when you're in health. So if you're in the NHS, there are lots of points at which you generate data on yourself and your care. If you're in a care home, or if you're being cared for in the community, or if you are a carer of someone in your family, you don't generate as much information on yourself, and therefore the system doesn't have as much information on your needs, and it can't necessarily utilize the types of technologies that I'm talking about in the same way, because they're all very much data hungry technologies. So they rely on that input data. And if there are great big gaps in the input data, as there definitely are in the care environment, it makes it infinitely harder to build technologies that don't have issues, for example, like data bias. Like, there will definitely be people that we have more information on than others. And that might mean that we might favor them if you were to deploy a technology that knows more about one type of person than another type of person. So for the aspect of people who are in care, the biggest issue that we have is the quality of the data going into these types of technology.
And presumably, I mean, you said it's very different for different groups, but people, obviously there's some groups who might use technology more than others. I know that a few years ago, I wasn't on Twitter, I wasn't on Instagram, I wasn't using a lot of things, and now I am. And people who are younger than me presumably might want to use it more, and people who are older, who are accessing the care system, maybe home care, might use it even less because they just don't need to. So that data bias could affect those groups potentially a bit more than others.
Yeah, exactly. One of the things that's a very big risk is that you start to, what I sometimes call, overfitting the system. So there are people like me who I use the care system quite a lot. I have long-term conditions, so I interact with the healthcare system a lot, but also I do what I do. So I am super comfortable with generating information on myself, and whether I use my Fitbit or I use the NHS app or all of these types of things. But therefore I can have the system knows much more about me than the other types of people. And what we have to do is, the reason why the system wants to make sure that it uses these technologies is because there are efficiency gains. They're massively more efficient to treat a person or to see a person via digital technology than it is to do face-to-face. And sometimes it's also better for the person. You don't necessarily want to travel somewhere. You might want to talk to your clinician or something at home. But you have to give people the choice. It's very important that people have the choice how they want to interact with the care system, and so people don't get completely forgotten about. And there are two layers to that. There's the one that is making sure that the physical services still get the funding, to make sure that those who want to interact with the care system on a face-to-face basis can do. And the second aspect is that this is the secondary uses of data. So data is also used not just for purposes of direct care, so not just for making sure you have information about what medications you're on or anything like this. It's also used for planning, and there are ways you can opt out of that happening, but essentially there's also a whole use of data for planning. Where do services go? Where do we need to train clinicians in? And if there's a whole group of people who aren't generating the data on themselves for a variety of reasons, they're not in that data set that planning goes on. And so they therefore might not have the services planned for them that they actually need. So we need to make sure that the system as a whole knows about all of the people that it needs to care for, regardless of whether or not they generate the same amount of data as people like me do.
That's a huge challenge.
So
I suppose, I know that certain places like digital social care and other organisations that are cropping up are trying to encourage more people who either use care services or deliver care services to use data. So potentially that sort of push will help those anomalies where you have a lacuna in data for certain groups. Also, I would want to talk about, I don't know if you've mentioned some of this in what you've been saying, your work with the datalab. Mm-hmm. So is that the Oxford University work that you're doing? Could you talk about that?
Absolutely. I have two different hats at Oxford University. I have the datalab hat, which is one that you're describing, where I'm the policy lead, and the data lab sits within the primary healthcare department, so Nuffield Department of Primary Healthcare, and that is directed by Dr. Ben Goldacre. And then I also have a role as a researcher and a student at the Oxford Internet Institute and the Digital Ethics Lab, which is where I currently am, and that is directed by Professor Luciano Ferridi. The word lab, I think, conjures up images of people in white coats with test tubes, and especially in a clinical sense, that's definitely what people think of as being a lab. We tend to use lab to mean research group. So in both of those instances, what we just mean is a group of researchers who research on a similar theme, and we sort of get together and talk about it. And we happen to use the word lab. This is why I'm wearing a Batman t-shirt and not a white coat.
Okay. No pet fishes in sight.
Yeah, exactly. But there are two, they've kind of perform two different roles. So the role of the data lab is to use data to improve medicine and improve all aspects of care. So it does lots of research, for example, open prescribing, which is a massive open source piece of software that's used by vast majority of general practices in the UK to look at patterns in prescribing, when that can identify where there may be issues with overprescribing or people not being compliant with guidelines, all of these kind of things. And it does a whole lot of research is related to that. And one of the things that I do as the policy lead is look at where we might have regulatory, cultural, technological barriers to the better use of data for improvements of care. And in the Oxford Internet Institute, it's a multidisciplinary department, so people do research on all sorts of different stuff. I focus on health data, unsurprisingly, and look at the practical implementation of sort of ethical principles. So how do you make sure that you're using data for good and that it is used for the purposes of delivering benefits, but also make sure that you can mitigate the risks?
One of the questions that I had around the use of data for policy, I was thinking about, there's a recent consultation by the Department of Health and Social Care, I think, and also maybe the Cabinet Office, around prevention in the 2020s. And some of the questions are very much towards what responsibilization, what can the person do to take responsibility for their own health, which is definitely something that people need to pay attention to. But does looking at data and the way that people use data focus too much on the individual and not so much on the wider determinants of good health, sort of like the systems and the structures, the food industry, for example, or do you see that happening in the use of data in policy at all?
Yeah, I think that's a super important question. So I think one of the thing you're talking about is the PHC, or whatever it's called, is like paperless 2020 is the strategy that was out from the department a couple of years ago. So one of the pieces of research that I have done in the Oxford Internet Institute is with Luciano is on the concept of empowerment and data empowerment, and whether this idea that you just look at information on yourself, whether it be through any type of app or a website or whatever, and you automatically know how to improve your healthcare, and therefore if you are, as you've just said, responsible for making the decision based on that information. I think that there are a number of problems with that, and one of them is that, exactly as you've just said, it shifts the responsibility away from the centre onto the individual, to say, we've given you all of the information about how you can improve your health, and if you didn't decide to take that action, then it's kind of your fault. And I don't necessarily think that's the intent when policymakers use that type of language. They're using empowerment in a positive sense, but it doesn't necessarily take into account the wider context and how a person might interpret that. So one of the things that I'm big on is that instead of data being considered about empower the person, consider it as being enable the group. So you might, for example, be able to learn that, people in this area, for example, they have no access to fresh fruit and vegetables, or it's way too expensive for them, or there is nowhere to send your children to get exercise, or exactly like you've just said, or things like long-term conditions or rarer diseases, which are currently hard to diagnose or identify because we don't have the information on how to pick up on the symptoms. Those are things that you can do by aggregation of data that I think will have a bigger impact on the overarching improvement of care, and therefore by default the outcomes of individuals, than by focusing on the ways that individuals interact with their health information.
Yeah, I think that's really sort of something to take into consideration for policymakers, especially. And it's interesting that you've kind of found the same issues that I was thinking about. So we had a few questions from social media, and some of them I don't really understand, but I'm hoping you might. So one of them is about, so someone obviously went out to social media and asked if they had any questions for you, and one of them asked was so black box AI versus interpretable AI in healthcare. And I suppose the question is, what are your thoughts on either or? And and how to make sure that patients receive the correct information, and what would that be? And that's from Laura.
Okay. So what she's getting at there, or they're getting at, is this problem that complicated or complex algorithms that are used in some types of AI techniques, particularly machine learning or deep learning and unsupervised machine learning, we have very little oversight of what happens in the middle of that algorithm. So if you've taken old, or what's often called GoFi, good old-fashioned AI, it works very much like statistics. You, as the programmer, know exactly what you're telling the algorithm to do. And an algorithm in this sense is just a set of instructions. So you're trying to get to an outcome and you're telling it how to get to that outcome. In machine learning, you tell it, you give it the input, which is the data, and you tell it the output that you want, but you don't necessarily tell it the instructions. It goes and kind of works out the instructions itself. And the amount of information that could be in that instructions is huge. So it might decide to take into account the color of the sky on a particular day that somebody happened to have a headache, and we would never have thought to put that information in. So there are concerns in the whole of machine learning and AI community that should we be able to explain how an algorithm has reached its decision in order to be fair. Now, this has particular implications in health because of the idea of informed consent. And you must be able to understand how a decision has been made about you and why you are being told to take a certain action. So you don't necessarily want to have a conversation with your doctor where they go, right, well, we've prescribed you this drug, and you say, why? And the doctor says, I don't know the drug, the computer has just told me to. So there are ways of making AI interpretable through things that are most likely statistical techniques. So there's a thing, for example, that's called a saliency map. No one needs to remember that word, but what it will do is if you have used an algorithm to diagnose an image, it will show you through pixels what parts of the image it has recognized as being abnormal and therefore given you an abnormal result by highlighting it.
Yeah.
That can do things like tell you whether the algorithm has made a decision based on something completely erroneous, like why has it picked up on this tiny thing and that's not a problem. So that can make it interpretable. That doesn't necessarily work in the same way when you are doing, for example, diagnostics based on the way that somebody has typed in symptoms. And so this is where the whole debate comes in. My view on it is that we have to be pragmatic. So it is important that we understand the overarching system of how an algorithm has come to make a decision. So we know where it got the data from, and we know that there was a process that checked that the way that that algorithm was validated was accurate. I don't think we necessarily need to go down the route of making it so that a clinician in a hospital knows exactly the weightings of that instruction bit of an algorithm in order to be able to have a realistic conversation with a patient. So there's a broader concept of procedural regularity that I think is important. So making sure we know how an algorithm was developed, where the data was, where it breaks, and how it was validated and how it is continuously monitored, I think is more important than necessarily being able to explain a specific decision.
It's almost how it came to that decision so that you can trace back any of the determinants that went into that decision-making process.
Exactly.
Yeah. Thank you. You've explained something which I think I would have found very complex otherwise. So that was brilliant. And I'm sure that's answered Laura's question. So Colin Patterson asks, if you could hire 3 people into the NHS, who would that be and why?
So full disclosure, Colin works for NHSx. He's
Okay.
one of my colleagues who is
Right.
a brilliant product manager inside NHSx. And this question, I think, is very difficult. I think he said, do they have to be alive? I'm not sure.
He hasn't said that, but he said no price tag or even pulse. No, he has said even pulse. Yeah.
Yeah, no price tag or pulse. So does the living or dead? I would, I think, have Marie Curie for one, because she's kind of been there when we first got our head around radiology and redesigning that and what that meant. And that is effectively what we are doing now with AI, is redesigning the way that imaging works and screening works within the healthcare system. So I think she would be a good person to have on hand. I would probably have then someone from the gang of computer scientists, Alan Turing being the first one, to help us understand exactly what it is that we're doing. Also to think through the implications. So lots of people sometimes think that the ethical AI and AI in general is a new thing. It's been something that people have been aware since the 1940s. So legacy helps in that instance. And then the third person, I think this is a more complicated one because I don't think employment works, but I think we need to have a better way of having patient voices involved from the beginning of policy making, and that being a more systematic way. I'm not convinced hiring is the right way because then they become conflicted, but whether there's a way of funding more systematic engagement for different groups of engagement in policy within NHS and within NHSx specifically, I think is the third thing I would want.
Maybe you're talking a little bit about co-production there.
Yeah, probably.
I think it just makes sense, doesn't it? You've got the end user, and to have their views in the whole process, that would hopefully enrich it, probably complicate it, but at the end it will enrich it. So that's so enlightening that you mentioned that. But Alan Turing, I don't really know who that is, I'm sorry. I probably should.
No, not necessarily. You wouldn't if you're not a data nerd. He's largely considered to be the founder or the father of artificial intelligence, especially in the UK. So the Alan Turing Institute, for example, is the UK's data science centre, space inside the British Library. And he did all of the very foundational work on the use of artificial intelligence during World War II, and the creation of Enigma, which was breaking code that was being used by the Germans. So it's the whole entire field is effectively founded on most of his calculations from back in the day. And so I'm fairly certain he has some insights into where we could take the field next. And one of the things I think we want to always be aware of, and we have failed in the past as the government, is to be reactive rather than proactive with the use of technology in health and care, and not get ahead of the curve, and so make decisions that then make it harder to deploy technology that develops in the future. And so I think having someone who is able to think right at the cutting edge, like Turing, would maybe help prevent us from doing that again.
That's an interesting point, because in health and social care you're often told to try and be proactive and think about what's coming ahead so that you can plan for it, and you're not firefighting, but in this instance it's the other way around, so that you are dealing with issues as they come up, and you're, I suppose, more fit for purpose in that way. Great. So another question that we have is from David Waller, and he asks, any chance of putting some health economics into the health informatics? How do we get best value if we don't measure it properly?
So this is a question that I think is fascinating. I don't necessarily have an answer to how do we do that, and in terms of an answer to should we do it, yes. So health economics, for people who might not know, is the kind of way that you might calculate why do we choose this type of treatment instead of that type of treatment, and why does NICE, for example, through health technology assessments, recommend that you use this drug instead of this one, or you use this diagnostic tool instead of that one. And it's a really key part of decision making, especially when you're dealing with public money, and you don't want to waste public money. Now, there is I would say, a fairly big problem in that most digital health technologies do not have a framework for evaluating them in a standardized manner in order to do that kind of health economics analysis. So with health economics, of traditional health economics, there's a very set way of you identifying the cost and the benefit, etc. With digital health technologies, we don't have that yet. There are things that are in the pipeline. NICE has the guidelines for evidence of efficacy and economic impact, but it's very high level. It's quite abstract at the moment. And part of the problem is that these technologies have not existed for such a long time for us to be able to identify impact. And one of them might be, particularly in the care space, I think is an interesting one, is one of the sort of key aspects of health economics might be like return on investment. And if what we're doing is using an intervention that enables a person to look after themselves and not go into hospital, we're making the cost benefit analysis on a potential future scenario that may or may not have actually happened had we not had that digital health intervention. So these are all questions that we need to work out. How do you do that evaluation, and how do you do proper impact modeling for data-driven technologies that we might have done with a drug or a different type of health technology? And so the short answer is we absolutely should. What that looks like, I'm not sure yet.
And I suppose, in a sense, NHSx is so very young at the moment, and there's so much to get to grips with, that these type of answers and conundrums and answers to these conundrums will continue to happen as technology advances and as data is on the catch-up of informing policy.
Yeah, absolutely. But I think there's a big role for the wider systems. There's a huge role for academia in this space, for working out and doing the maths and all of that type of stuff, and that answers these questions. And what the government can do is make sure there's funding for that type of research. You know, often research in any field, but particularly in this type of space, is all driven towards either the sexy tech, so what's going to get you a headline, or to engagement, softer social sciencey type stuff, which has a huge role, obviously, but there is also a need to fund proper research in economic evaluation of digital health technologies, in standards for the development of informatics. All of these things need to be funded so that the whole system that goes into producing policy is enabled to help support that mechanism, make the best decisions for the future.
One of the things that I sometimes sort of think about with this is that with technology, it's not, I mean, you've got the NHS, which we pay our taxes for, and we feel that we have a reasonable amount of control over and input and say. With the technologies, it's like a whole new world, and presumably they're owned by private companies and we've become so reliant on them. Is the whole digital sort of race almost going towards privatising the NHS?
So that's definitely a question that comes up a lot, and I think it's a tricky one. The short answer is no. You're not privatising the NHS in the sense that these are not third parties, private companies running NHS services, but so it's not a privatisation mechanism, but what it is doing is complicating the number of actors who are involved in the overarching system of the NHS. So there are now people who come in who help develop services or help think about data use, or that are outside of the NHS family, I guess. And there is a huge responsibility on the centre to make sure that when those relationships happen and that system begets more complicated, it happens in a way that everyone feels comfortable. And the big thing for me there is that it has to be transparent. So there needs to be trust. If we lose public trust in that overarching mechanism, then we've lost the whole endeavour. And so making sure that people are transparent from the beginning about what contractual arrangements are in place, why that decision was made, why one company was chosen over another, and even things like publishing your data protection impact assessment, or your data sharing agreement, or the KPIs to the performance of these things should be published, and they should be publicly available. And even things like analytical code should be shared in the open, so that there is transparency over the whole process. And I think if we have that, we can build public trust in this more complex mechanism of different participants in the system.
Do you think, I mean, that's a great idea. Do you think there would be appetite for doing that?
I think the message has to come from above that we are not playing with you unless you want to be transparent about this. And over time it becomes a norm, it becomes the social norm that is what you do. And at the moment, things like people get they use things like trade secrecy or IP as necessarily a way of avoiding wanting to have that level of transparency. And these are complicated questions that we're going to have to tackle. But I think if you make it the norm, and you make it socially acceptable and to do that, and socially unacceptable not to share, and there are levers that the government can pull to help that process, whether that be through procurement frameworks, for example, I think you can make that appetite grow.
I feel like that's a really good question and suggestion I will put to any type of politician who will allow me to interview them, because that's really good. So we've come almost to the end, and I usually ask a few cactus questions to people, and these are quickly questions about health and social care. I didn't have any, but I thought of some as we were going along. Actually, the last one is pretty quickly a little bit. But one of the questions I had, and that was coming from your idea of being more open and having more people with experience involved in the data analysis research that you're doing. Obviously, NHSx is quite new. Do you feel that it has communicated its purpose and its existence enough to even professionals in health and social care?
Oh, that is a good question. I definitely think it's tried. It's definitely the most open to open policy making government institution that I've ever been involved in. It's very public facing on social media. We've done lots and lots of engagement activities, and does it in a federated model as well. So sometimes there's something to be said about government organisation not necessarily being the right group to have those conversations with members of the public, or publics or groups, because people feel uncomfortable being transparent and honest. And so groups like Ada Lovelace or Understanding Patient Data, or you guys with Coproduce Care, can actually really facilitate those conversations much better, and then NHSx can be responsible for listening to the messages that it gets back. I go to a lot of conferences as me, not as NHSx, and people don't know that it exists. So I think it's probably needs to the word needs to disseminate further, but that may happen over time.
Yeah, I'm hopeful that it will, because the more I learn about it, the more I hear people talk about it, the more I feel that there's such a need for something like NHSx, and it has the potential to play such a huge role in informing how we use data and how we use technology in health, and then over in social care as well. So it would be great if more people knew about it. And then obviously, if it comes to a stage when it does want to have better public engagement, then obviously the awareness is already there. So yeah, watch this space, I suppose. Another question was this is probably like an old question really that you get asked a lot, but data in health I think is very useful in terms of thinking about diagnosis or how people are using different services, but it's sometimes difficult to see how useful it would be in social care, and whether, because social care is innately personal, is the sort of advent of AI and data and technology taking away a personal aspect of care, and is that necessarily positive?
Yeah, that's a really, really good question, and I definitely signpost anyone who's interested in data space in social care to check out work by Everyone and also by Future Care Capital, who are really the specialists in this space, and they have some excellent research on this topic. From my perspective, I think this is one of the things that actually Luciano in OII talks a lot about is semantic capital. So this idea of what is a human that's uniquely human that we can't take away from. And at the end of the day, an algorithm or something like this does not have an emotion. It doesn't have an emotional connection to a person. It doesn't necessarily have a tactile element to it. All of these things are the personal aspects of care that a person is always going to need. So we are only ever talking about, with the AI in general, facilitation and augmenting the overarching care pathway. I don't like messages that come out in the press of we are replacing a clinician or this or a carer. I think they're erroneous messages, and they don't help the people understand what it is that we're trying to achieve. So I think there is a risk that you take away some of the personal element of it, not in terms of the understanding of the person, because you are actually, in theory, generating infinitely more personal information on that person and can learn way more about them, and therefore tailor services to them much better than you can in a non-datafied space. But the caring of the overall human and the person, and understanding who they are and their feelings and how they might change, and the concept of dignity, I think always needs to be maintained by there being physical human carers involved in that process.
Yeah, I mean, that's really good to hear, I think, because I've spoken to a few people who have been into China and Japan, and they've looked at very human-looking robots who can provide company for people who are by themselves. So I do understand the argument for that, but I think traditionally in care we are just quite we're used to giving sort of care personally. So I think the debate needs to happen when it's a real issue, something like that. At the moment, it's just technology, sort of research, I suppose. But it's interesting to think about. Great. Okay, so we've come to the end. I feel like I could sit and listen to you for a very long time. You're very interesting. I'm sure, hopefully, maybe after this we'll have more questions and maybe we'll have you back again. But thank you so much for joining us on the Coproduce Care Chat.
No problem. Thanks so much for having me.